Optimal timing of epiretinal membrane surgery maximizes visual preservation. These are fibrocellular growth on retinal surface causing metamorphopsia and defective vision, surgery routinely done for symptomatic patients in a late stage. Here we can see a clinical case scenario. On the right side, that is a chronic ERM or a long-standing ERM, which underwent surgery to regain vision to 618 from 660. However, the vision didn't improve further. That was because of the disorganization of the inner retinal nerve fiber layer, which can be seen from the post-op OCT. On the left side, you can see an early ERM. After, after surgery, the patient regained 6-6 vision with a maintained foveal contour. Then why do surgeons wait till the disease worsens? Vitrectomy related complications can be severe. Also, surgical trauma can cause decreased vision sometimes. Many times, there is a little room for improvement in early cases. ERMs tend to remain stable for many years. Our purpose was to establish whether early vitrectomy for symptomatic idiopathic epiretinal membrane is preferable to delayed surgery. We did a retrospective study of 41 patients from April 2016 to February 2023, and surgery was done by a single senior vitreoretinal surgeon. We included all patients with symptomatic idiopathic ERM with visual acuity documented as 660 or better, and excluded patients with secondary ERMs, coexisting retinal or disc pathologies, and also significant cataract. We then categorized the patients on the basis of their preoperative logMAR score. logMAR 0.3 or less was considered as early surgery group. logMAR 0.4 or more was considered as late surgery group. We then took the values of visual acuity and central foveal thickness at preoperative and postoperative 1 month, 2 month, and 6 month period and compared these values in both early and late group. For statistical analysis, I used student t-test and modified Wall method. 48% of the patients were in early group and 51% of the patients were in late group. Majority of the patients were phakics in both the groups. When we see the CFT at postoperative 6 months, we can see that it was comparable in both early and late group. Whereas when we compare the BCVA in early and late group, we can see that the early group had better visual acuity at postoperative 1 month, 2 month, and 6 month. Majority of the patients in early group had logMAR 0.1 or better. Comparing other parameters, 95% of the patients in the early group had logMAR 0.1 or better, compared to only 76% of the patients in late group which had logMAR 0.1 or better. 80% of the patients in early group had improved vision. 15% it remained same, and 5%, that is one patient, it deteriorated. And in late group, 95% of the patients had improved vision, and 4% it remains same. Vitrectomy related complications we faced were, we had 2 cases of dissociated optic nerve fiber layer. It had no effect on visual acuity. There was a case of focal ellipsoid loss. He had a 1-line loss in vision. Mean CFT of both the groups were comparable, and none of the patients in both the groups had normal CFT. However, early group had better vision, by which we may assume that normal CFT may not be a predictor for better final BCVA. And it is a chronicity of traction that would negatively affect the final BCVA. Majority of our study population in both the groups had cataract and underwent combined surgery, thereby negating the confounding variable. In our study, 95% of the patients had logMAR 0.1 or better in the early group, compared to only 36% in Rahman et al. Study. 22% of the patients in Chinsky and et al. Study had worse vision post-surgery, compared to only 2% of patients in our study. This study strongly indicates that epiretinal membrane peel surgery is a viable option for patients who exhibit significant symptoms even with good pre-op BCVA, as now early surgery is associated with lesser complications, better anatomy, and better vision. These are my references. Thank you.
Thank you. Just one quick question. So should you do an early surgery when you're doing cataract surgery, or should you do cataract surgery when you're doing an early ERM peeling? Let me rephrase that question. was the cataract surgery need the indication also to do the ERM surgery? Or did you decide to do ERM surgery and therefore you also did cataract surgery so that you don't have to go back in 6 months?
Yes, sir. Since we had to do a DRM surgery, we did a combined surgery of both a cataract and DRM.
So all 41 patients had cataract. I mean, those who were not pseudophakic all had cataract surgery.
6 patients were pseudophakic. Rest of the patients were having cataract, and it was on the when we compared, almost the grade was comparable in both the groups.
Okay, but then most of them had, some of them had 6.6, 6.9 vision. So they had ERM with cataract, but because of the ERM surgery, then cataract surgery was done. It's
Yes,
not
sir.
that that cataract was very significant.
Yes, sir.
Were all the ERMs idiopathic?
Yes, ma'am. We selected the only idiopathic symptomatic ARMs.
Okay. You're basing the early and the late on the basis of visual acuity.
Yes, ma'am.
How do you explain that? Because the severity of ERM would also affect the visual acuity. You know, you can have a very rapidly evolving ERM. So how do you use visual acuity to decide whether it's a early ERM or a late ERM?
Ma'am, normally the surgeries is indicated when, usually performed when visual acuity is much worse. So we were just looking for symptomatic patients with ERM. And even with better visual acuity, we did the surgery on those patients. Thanks.